this event. And thanks again for the introduction. Professor Sufyan is one of my sincere friends in the Middle East AO. Now we will move to the internal fixation of open fractures. Our objectives are to discuss the principles and benefits of fixation of open fracture, timing of surgical interference in open fractures, methods of internal fixation, primary versus staged approach of internal fixation, and lastly, the orthoplastic approach. And thanks to Dr. Sufyan, who spoke about this issue as well. What are the main goals in management of open fractures? To achieve well-aligned bone union, to avoid complications, and to restore the function. The decision-making significantly affect the long-term outcomes. So decision-making in open fracture is sometimes difficult. And although we have evidence-based recommendations that may guide our decisions, still we have several areas that continue to be controversial. This is a special issue about open fractures in the Journal of Orthopedic Trauma Association. And it is recently published. And they still talk about open fracture management with critical unsolved issues. What are the main principles of management that we always talk about? The antibiotic prophylaxis, wound irrigation and debridement, skeletal stabilization, wound closure and soft tissue coverage, local antibiotic delivery, and the adjunct therapy for fracture healing. We always receive questions about these issues, and we are going to talk about the skeletal stabilization. What are the benefits of stabilization of open fractures? We protect the soft tissues from further injury. We improve the wound care and the tissue healing. We promote early mobilization and rehabilitation by skeletal stabilization. Moreover, restoration of length helps decrease soft tissue dead spaces and decrease the rates of infection in open fracture. How can skeletal stabilization decrease the incidence of infection in open fracture? This is a newly published article in the Injury this year. And this is the mechanism how stabilization of the bone will decrease the incidence of infection. The instability that causes continuous movement at the fracture site will initiate several traumas of the soft tissue and ongoing soft tissue trauma that will initiate an inflammatory reaction and suppress the local immune mechanism as well as forming the hematoma. Again, it interrupts the new vascularity and cause osteolysis of the bone. These all will support the environment for bacterial growth and infection. Lastly, what are the factors that affect our decision to choose the method of fixation, whether to go with external fixation, internal fixation? This will depend upon the fractured bone, fracture location, intra-articular, metaphyseal, diaphyseal. Most important is extent of soft tissue injury as figured out by Dr. Sufyan, degree of wound contamination, and lastly, the physiologic status of the patient. How is the polytraumatized patient, the state of the general state of the patient, and the stability of the patient? We all know the available methods ranging from skeletal traction, passing through external fixation methods, intramedullary nailing, and plates. The external fixator is the working horse in open fractures. It is one of the most valuable tools in the surgeon's arsenal for the management of grossly contaminated open fractures with extensive soft tissue injury, type 3 A to C injuries, and as a part of damage control in polytraumatized patient when the patient is physiologically unstable. What about internal fixation of fractures? We will start with plate fixation. It is applied in open upper extremity fractures and in open periarticular fractures with reconstruction of the articular surface. However, it reports higher infection rates. So carefulness is needed when we decide to go with plate fixation. It should be applied with the art of minimal invasive techniques. Although current plating technology and these less invasive techniques are reporting good to excellent results, again, we should take the decision with great caution. This is an example, this article describing the plate fixation by minimal invasive technique in open fractures of the proximal tibia. Prerequisite is soft tissue reconstruction can be performed adequately and simultaneously. What about intramedullary nailing in open fractures? It is one of the mainstays of treatment for most femoral as well as tibial shaft fractures. For the femur, there is sufficient evidence to support reamed intramedullary nailing. In this study, the reamed intramedullary nailing reported no infections with type 1, 2, and 3A, but 11% with type 3B. So it seems that intramedullary nailing for the femur is safe from type 1 to type 3A. What is the level of evidence to recommend intramedullary nailing for the femur? It is fair evidence. This means level 2 or 3 studies with consistent findings. So for the femur, we have evidence to support reamed intramedullary nail of the femur. What about the tibia? The optimal treatment of open fractures of the tibia is less clear. When we see the literature in the late 80s, they report favorable outcomes with X-fix. During the 90s, unreamed intramedullary nail came into use and was preferred to external fixator. In the later years, there is always a debate whether to ream or to use unreamed nail for the tibia. Many studies comparing reamed and unreamed nailing in patients with open tibial fractures have proved inconclusive. And we will come across this issue. This is an international survey among orthopedic surgeons from different countries, including 444 surgeons. 88% of surgeons use intramedullary nailing for open type 1 and 2 tibial shaft. They agree. 88% agree to use it in type 1 and 2. 68% for type 3, but only 48% for type 3B open tibial shaft fractures. And they preferred the external fixator to the nail in this situation. What is the evidence for the tibia? For the external fixator and unreamed intramedullary nailing, we have fair evidence. This means, again, level 2 or 3 studies with consistent findings. But for reaming of the tibia, we still have insufficient evidence to support reaming. We have many reports of unreamed intramedullary nailing for open fractures of the tibia, reporting satisfactory union and low complication rate. If we go through the publications comparing reamed versus unreamed intramedullary nail, this is a study published in the Journal of Evidence-Based Medicine and Healthcare, a prospective comparative study including 100 patients with open fracture tibia, 50 patients reamed, 50 unreamed. They excluded severely comminuted fractures and Gastello types 3B and 3C. They report similar clinical and radiographic results when they compared both groups. Again, another comparative study comparing reamed to unreamed nail, including open tibial fractures from type 1 to 3A. Time to complete union was similar in both groups. Adequate debridement of the wound and soft tissue coverage are the key to minimize deep infection, irrespective of whether the bone is reamed or not. This is the largest study, and it is well known in the literature as a SPRINT study. Comparing, it is a randomized trial of reamed and unreamed intramedullary nailing of the tibial shaft, including both closed and open fractures. And they concluded benefit for reaming in patients with closed fractures, no difference with open fractures, and they recommend delaying the decision of reoperation for non-union for at least 6 months. This may decrease the overall need for reoperation, as some fractures will heal later. What about external fixator versus unreamed tibial nail? Again, we have many publications. This is one of the old publications coming from Hanover Group, Germany in 1995, comparing unreamed tibial nail to the external fixator, including 48 patients in the unreamed group and 66 patients in the external fixator group. They report up to 19% bolt breakage of the unreamed tibial nail and 26% pin track infection in the X-fix group. And the good results in both groups are nearly comparable, with higher reoperation rate in the external fixator group. So the main drawback of using unreamed tibial nail is bolt breakage. Again, this is comparison in a randomized prospective study, unreamed versus external fixator in Gastello 1 to 3A. No statistically significant difference between unreamed tibial nail and external fixator. The advantage in the nailing group, ease of weight bearing, absence of angular deformities, absence of joint stiffness. So they recommend unreamed tibial nail for Gastello 1 to A3, open tibial fracture. This is a meta-analysis of randomized controlled trials comparing external fixators to unreamed tibial nail. They are similar in deep infection, delayed union, and non-union. However, the unreamed tibial nail showing reduction of the superficial infection, no pin track infection, and less malunion compared with external fixator. However, the external fixator showed significant reduction in hardware failure because unreamed tibial nail reports more incidence of bolt breakage. So when we go through the literature, we find the external fixators are a good, reliable method of stabilization for all types of open fractures, especially type 3B, while the unreamed tibial nail gives better results in Gastello 1, 2, and 3A. when we compare all methods of fixation to the reoperation rate in open fractures of the tibia, we have this article published in the Clinical Orthopedic and Related Research. It is a network meta-analysis, level 1 evidence. Unreamed tibial nail showed lower risk of reoperation, and the plate fixation showed the highest risk of reoperation. If we have a gradient, unreamed nailing being the highest ranked, this means lowest risk of reoperation, followed by reamed nailing, external fixator, and plate fixation showed the highest risk of reoperation. What about infection after intramedullary nailing? We have many different reports. One of these reports, this multivariate analysis of different factors contributing to infection after intramedullary nailing of open fractures of the femoral shaft. They report deep infections in 5.6%, non-union in 14.1%. What are the factors? Severity of soft tissue injury is the significant risk factor for infection. However, fracture severity is the significant risk factor for non-union. Another study, time to treatment is the only risk factor of infection. So we have now the severity of soft tissue injury, one risk factor, time to treatment, another risk factor, and again, non-union is related to the comminution grading of the fracture, and they recommend rigorous debridement before primary intramedullary nailing. Again, this article recommends quality of debridement of soft tissues performed by an experienced surgeon is one of the crucial factors to have a successful primary intramedullary nailing in open fractures, in addition to viable soft tissue coverage to prevent secondary necrosis of the bone and development of deep infection. The decision to do primary nailing or not depends on the fracture type, the grade of comminution, and on the degree of contamination of the wound. And they recommend, if the soft tissue condition is not safe, to have a staged protocol with repeated wound debridement, secondary wound closure, and conversion to intramedullary nailing as soon as the patient or local soft tissue permits. So we have now in our practice the staged approach or the temporary external fixator as a line of treatment till the patient condition allows in damage control surgery of polytrauma patient, or the local conditions allow according to the management of the soft tissue and adequate debridement of the wound. The main indications of this staged approach, I think the situation of the soft tissue will be number one, and number two, if internal fixation is not healthy enough for the patient, and number three, very important, if we don't have the facility to provide the definitive standard care. So we should refer the patient to another center who will offer the best care of the patient, as figured out by Dr. Sufyan when you have your orthoplastic team. What about intramedullary nailing following external fixator in femoral and tibial shaft fractures? The conversion from external fixator to an intramedullary nail is a big issue, and we always raise a question about the safe duration to do primary conversion from X-fix to intramedullary nail. It should be less than 2 weeks. After 2 weeks, a question mark about the pin track infection is raised. So the second important prerequisite is absence of pin site infection. The conversion after pin site infection may require a period of time. We remove the external fixator, give antibiotic treatment before we go with intramedullary nailing after eradicating the pin site infection. The issue of secondary intramedullary nailing after external fixator is controversial. The infection risk depends on the wound severity and the presence of pin tract infection or the success of eradicating this pin tract infection. And in Gastello type 3B and 3C, secondary intramedullary nailing doesn't show superiority regarding the union or infection to a Lazaroff circular frame. How can we prevent infection in internal fixation of open fractures? Adequate debridement is the key. Early soft tissue coverage is another key. And we have also other factors. One of them, early antibiotic administration. This is a recent article published in the Journal of Injury. Delay of antibiotic administration greater than 2 hours predicts surgical site infection in open fracture. What about the use of local antibiotics? We have heterogeneous data about this. One of the articles recommending the use of gentamicin-loaded collagen sponge in internal fixation of open fracture reporting satisfactory outcome. Again, this is a recently published article in the Journal of Orthopedic Trauma Association about the early application of topical antibiotic powder in open fracture wounds to prevent biofilm formation and infection. We go to the systematic review and meta-analysis. Although we have limited quality and heterogeneity of the articles pooled in this study, and there is maybe hidden risk of bias, still this meta-analysis suggests a risk reduction of fracture-related infection about 11.9%, about 12% if additional local antibiotics are given prophylactically in addition to the systemic antibiotics. What is the future? The future is implant coating. The use of antibiotic-coated implants may be the future to use internal fixation devices in open fracture. And this is an article reporting the use of gentamicin-coated nails in complex open tibial fractures and revision cases. They report 16 patients included in the study with encouraging outcome. What about the timing of fixation? It is well covered by Dr. Sufyan. The 6-hour rule, it is well accepted, but there is no evidence to support it. The time from injury to debridement is less important than adequacy of debridement and the timeliness of soft tissue coverage. So debridement and soft tissue coverage should take the priority when we think about the timing of interference. We should have the team. The team should be ready. So again, to answer the question, middle of the night or the light of the day, which fractures, what time? We have the important factors more than the 6 hours. Early antibiotic administration, performing thorough debridement, and the appropriate surgical team. In a survey among the Orthopedic Trauma Association members, 99.7% of respondents agreed that the irrigation and debridement within 12 hours for type 3A fracture is accepted. And the debridement should be performed using the fasciotomy lines for wound extension when possible. What about timing? These are the recommendations of the British Orthopedic Association, together with the British Association for Plastic Reconstructive Surgery. The timing, they recommend immediate debridement in highly contaminated wound, agricultural, aquatic, sewage, or when there is an associated vascular injury, compartment syndrome, arterial injury, within 12 hours for high energy open fractures and up to 24 hours for low energy open fractures. What is important here is availability of the appropriate team. The last point in my talk, the orthoplastic approach for open fractures needing coverage. One of the earliest reports, that of Marco Godina in 1986, who recommended early microsurgical reconstruction of complex trauma of the extremities with internal fixation of fractures, applying the protocol of aggressive debridement, soft tissue reconstruction, internal fixation of the fracture, all at once by a dedicated team. We have this famous publication, Fix and Flap, the radical orthopedic and plastic treatment of severe open fractures of the tibia in 3B, 3C open fractures. They applied radical protocol, radical debridement of the wound, skeletal stabilization, early soft tissue coverage, even with vascularized muscle flap. It is a combined orthopedic and plastic surgery service. And they found out delay in cover more than 72 hours is associated with most of the complications. So early coverage is required exactly as figured out by Dr. Sufyan. Radical debridement and stabilization should be done by a team, senior members of orthopedic and plastic surgery. And this combined work led to treatment guidelines that we have standards of management of open fractures. It was published first in 2009 and then updated. And we have many publications recommending this single stage orthoplastic reconstruction with reduction of the infection rate and good functional outcome, and also reduction of the recovery time of the patient. These are the updated guidelines published in 2017. The management plan for open fractures and surgery for initial debridement should be undertaken by consultants in orthopedic and plastic surgery, a combined orthoplastic approach, and the time limit is 72 hours. Definitive internal stabilization should be done at the same time of definitive coverage. Our take-home messages: decision-making to do primary internal fixation depends on the extent of soft tissue injury, the degree of wound contamination, the state of the patient, facility, and available resources. Timing depends on contamination, severity of injury, presence of vascular injury, availability of the experienced surgical teams. Primary reamed intramedullary nailing in open femoral fractures is supported by the evidence. Unreamed tibial nail for open tibial fractures is used with success, and there is controversial evidence whether to be reamed or unreamed. And again, we have the debate: unreamed tibial nail versus external fixator. Unreamed tibial nail has the disadvantage of bolt breakage. External fixator has the disadvantage of pin track infection. Plate fixation is used for upper extremity fractures and periarticular fractures. Staged approach if primary internal fixation is not feasible, either due to the general state of the patient or the local state of the wound. Orthoplastic approach is recommended for Gastello 3B and C. Thank you very much for your attention.
Thank you so much, our great professor, Professor Osama Farouk, for this very comprehensive talk. Thank you so much, sir. Dr. Ibrahim Amar from Sligo University, Ireland, is the moderator with Professor Osama Farouk. We have 2 minutes to receive questions to Professor Osama.
Thank you, Professor Osama, for this nice talk. And we received already the first question from Dr. Muhammad Shaban. He asking about your preference in management. You like to do IM nailing or X-fix?
In which type of open fracture?
I think the question is like general preference, like what you like to do, you know.
I think in type 1, we all agree that type 1 open fracture will be treated like closed fractures. So you can go with internal fixation in type 1 open fracture. In type 2, the magnitude of soft tissue injury, the muscle laceration, and the preosteal stripping is still confined to the zone of injury. So if you apply adequate debridement, wound irrigation, you can go with intramedullary nailing easily, especially it is open fracture. It guides you to do the reduction and introduction of the nail in shorter time. So the debate will be about type 3 fracture. And here it depends on the soft tissue laceration, the degree of contamination, and the time of presentation of the patient. If the patient presented in the night, then your decision mostly will be to do wound debridement, external fixator, second look, and then in the second look you may decide to go with internal fixation. And you have the consultants, the seniors from the orthopedic and plastic surgery as well. In 3B and C, I will be on the side of external fixator.
There is another question about there is any rule for plating an open fracture of the upper limb with soft tissue loss?
It's soft tissue loss. This means you don't have coverage of the bone or the implant.
This is the question, but I think the maybe coverage for bone, because if you can cover the implant, you can put the implant, I think.
You need then the combined work with your plastic surgeon in order to do radical debridement, to do the internal fixation and the coverage in one shot or one surgery. The infection rate in the upper limb is less than in the lower limb if
proper debridement done. Yeah.
Yes.
So if you are going for single stage, then we can go once and do the plating and the soft tissue coverage in the same setting, and that's it.
You know, such cases are taken case by case. You cannot generalize
a rule for cases. Everything.
Yes, yeah. Yes, it is taken case by case, and you should assess the associated vascular injury, the associated nerve injury.
We have another question. This question is asking about, I think, Dr. Muhammad Abdulhadi asking about a certain case. He has a case of open grade 3C distal tibia with the wound size about 5 centimeters, but with post-tibial. There is, I think, vascular, I think, posterior tibial artery injured and the vascular surgeon ligated. In this case, he asked if he can use plate with minimal invasive or you prefer to use the X-fix.
This is an already compromised limb regarding the vascularity, and the aim here is to put to do the wound debridement, to put external fixator, to align the limb, and to keep the remaining collaterals and observe the limb.
So to be more, to your advice to be less invasive in that.
I will be less invasive in such condition till the vascularity of the limb is certain.
Okay, thank you, sir. There is no more questions, and thank you again, Professor Osama, for this nice talk.
I would like to take the opinion of Professor Sufyan about the upper limb injury with lack of soft tissue, with soft tissue loss. What would you do?
First of all, I would like to congratulate, as usual, Osama has very brilliant talk and very updated.
Thank you very much.
If just to come back for the juniors to understand, if you see that we say that in femur you can put much more nailing than in the tibia, but what's the difference between them? It's the envelope. The envelope between the tibia and the femur is different. Then you have very nice, good blood supply in the femur, but in the tibia, it's much less important. More the envelope is good, more you can put different type of fixations. In the upper limb, the flaps are easier than the lower limb. You have in thoracic chest, you have reverse, you have radial, you have plexus, you have a lot of limbs in the upper limb. Osteosynthesis with the flap. Don't put the bone, because I've seen there was a question if you have exposed bone, what type of fixation there? No need to put an exposed bone. If you wanted the bone to heal, you have to give him the opportunity to have a good envelope, the good blood supply, and that it will heal.
Yes.
We will put the plate in upper limb. We'll put an upper limb. It's very easy to find the flap, lateral overbrace, antebrachial flap, a lot of flaps that you have in the upper limb. That's why we discussed several times in the AO what the need for the surgeon, young surgeon, to know at least 6 types of flaps to do in emergency cases. You don't know it for the plastic surgeon. You don't have to wait for the plastic surgeon if he's available or not available, and it gives you the opportunity to solve a lot of problems. I think we have the opportunity in the upper limb to cover the upper limb in the second day. On the third day, when you put your dressing, do your dressing and debridement of the second day or the third day, you have to cover. If it is covered, the problem is solved.
Thank you, Professor Sufyan, for this.
Thank you so much, Professor Osama Farouk. Thank you so much, Professor Sufyan Khalal, for this very valuable discussion. شكرا جزيلا أساتذتنا الأفاضل. Now we will move to the next presentation.